Welcome everybody to our panel discussion on docs with disabilities and chronic illnesses. Thank you all for coming and thank you to our participants. So I'll introduce each of you. So first we have Dr. Marasco. She's the professor of neurosurgery, pediatrics and plastic surgery and chair of the neurosurgery department. We also have Dr. O, assistant professor of family med, PM&R and urology, interim director for students services for students with disabilities, and director of adaptive sports and fitness at U of M. Then we have Dr. Solimanpour, associate professor of internal medicine and director for type 1 diabetes research. And then we have Dr. Zazov, our professor of and also chair of family medicine. So thank you all again for being here. I'm Alexa Mink. I'm a fourth year medical student here. So I'll start with just a basic question. I'd love to hear about your journeys and your careers in medicine, sort of how you got where you are and how disability might have played a role in that journey. So, Dr. Marasco, do you want to start?
Would you like me to start? Sure.
Yes, please.
I guess I would say I've always known that I wanted to be a doctor. I think I was probably 4 or 5 years old when I thought about becoming a physician. And the reason why I thought about it was I was raised by 2 parents who were very much children of the Great Depression. And so for me, the thought process was, how can I make myself useful and have a job that's going to be there for me for my entire life? My disability is a form of spina bifida. It's a closed defect in my case, but it meant that I always had a full-length leg brace and a built-up shoe. And I was needing that. I was, going to need that to walk. So for me, then going on to becoming a physician was something where I had a lot of familiarity with being a doctor. I had a lot of familiarity with people and patients, etc. I had my first surgery when I was just about 4 or 5 years old. Another one when I was 10 or 11. And so I really had spent a reasonable amount of time among doctors in hospitals, etc. I admired them. I thought they were amazing people. Columbia has over the arch, it says, of the most high cometh healing. And I guess somewhere in my head that kind of fit into my brain. And I wanted it. I wanted a job where I felt I was going to be able to help people. I knew I liked science. And so that's why I went into medicine. As I went through it and thought about becoming a neurosurgeon, I think people were kind of surprised. You've got to remember, I'm in an age and a time when there were very, 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 very few women neurosurgeons. You could count them on one hand. And then the second thing was, now I was a woman with a disability. But if you ask me which has been the more difficult thing to be in medicine, frankly, or in neurosurgery specifically, it was being a woman rather than being a person with a disability. I think the disability actually was in some ways a grace in that it protected me from some of the typical things that occur for many women who are in a predominantly male-dominated field. I think the other thing was, because I was such a hen's tooth in the world, I just created my own road. And in some ways, that's extraordinarily liberating. The people that I saw around me were all men. The very few women that I saw were people that I didn't necessarily relate to. And so I created my own road and felt that I had to decide what were the things that were important to me. And that was extraordinarily liberating. I think the one thing I did realize early on was that, at least for me, I tried very, 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 very hard to make no one aware of the fact that I had a disability. So for me, that meant I came early to work and got the job done so that even though it took me longer, it was done in such a way that no one saw that it was taking me longer. I stayed later to get it always done. And probably the proudest moment I had was when I was finishing up in medical school, and one of my classmates was talking to another person in another level about the woman in her class. This person was talking to her. She's, the woman in your class that has the brace. And I couldn't think who she was talking about. And it was only at the point when she said, the one that's going into neurosurgery, that she thought of me. That meant an enormous amount to me, that the thing that people thought about me was as a physician and as a surgeon, not necessarily as a person with a disability. And so I think in many ways, correctly or incorrectly, one of the things I've always tried to do is probably a little bit more, work a little harder, be a little tougher, be a little stronger. And I think sometimes now I've gotten older and a little bit wiser, I realize people's perceptions of me are just that, their perception. They aren't necessarily reality and they aren't necessarily my truth. But it's taken a few years and a lot of gray hair to get there. And I hope others will learn it faster than I did. But it's been a privilege to be a physician. And the one thing I did know is that I needed a little bit of accommodation. So for me, because I'm 4'10", and I was working a lot with 6'2", 3, 4, 5 men, one of the things I did have for most of the time I was in the OR was a step stool, which could rise or go up or down. And it really didn't interfere with anybody else. And it was really very useful because as opposed to taking the normal step stools that are there and taping them together, which makes them unstable, this was something that provided me with an easy accommodation that required very little in the way of work or effort. But that was something that one of my faculty working with the company said, hey, listen, let's try to find something better than you balancing on all these step stools. And we bought it, we created it, and I used it in the operating room for 30 years until I started having some difficulties and had some surgery, which had some complications to it. And now I use a wheelchair, and equally so, I can do my cases and be very comfortable in that. So my comment is that I think you have to be able to think outside the box and realize when minor things could make major differences and ease for you in the environment that you're working in. So doctors are not oftentimes easy patients. And I think we recognize that sometimes about ourselves and hopefully grow a little bit as physicians as we begin to recognize that as much as we'd like to deny it, we are no different than our patients. And we are one car accident, one chronic illness, one episode away from being a patient. And as much as we'd like to protect ourselves psychologically from that, and I think it's one of the reasons why we are not very good patients. It is truth.
Thank you for that. Dr. O, do you want to jump in? And
certainly. Thanks, Alexa. This is Dr. O speaking. I am a young to middle-aged Black man in gold Beats headphones. I've got dark rim glasses. I'm wearing a wooden bow tie. I've got on a plaid shirt, and my background is my office. I use he, him, his pronouns, and I identify as having a disability and as being a wheelchair user from a spinal cord injury in my 3rd year of orthopedic surgery residency. So, I think that first of all of us will have different perspectives. And I think it's important for you all to recognize that, because just like anything else, disability is diverse. And therefore there's no blanket statement that we will make today that you can take away and say, that's what it means to have a disability, or this is what I should do. I think you're going to hear, 4 people's perspectives today. And I will say I am honored to be on this panel with the 3 other individuals I'm on it with, because I learn from all of them and look forward to learning from one who I haven't had a chance to know quite as well yet. But I went through most of my medical journey without having a disability, and disability was not something that I thought of in my personal life, right? As an orthopedic surgery resident, I took care of patients with disabilities, but never really understood how inaccessible our world was, or how there were structures and systems in place that perpetuated ableism and the perfectionism of medicine that then makes someone with a disability feel as if they are not qualified to be there. The other thing about it, and I don't want to take away too much from some of my peers here, but I have a visible physical disability, which is very different, I think, in terms of the perceptions that others have in terms of when there's an invisible or non-apparent disability. So for me, when I entered the world, as I call it, from the other side of the stethoscope, it opened up my eyes to then see how the system of medicine truly treats people with disabilities. And it actually made me sad because I thought this is the one space where we should be more understanding of the diversity of the human experience. And it's a space that is not very welcoming of that. So that has been my journey now. I was an orthopedic surgeon, and prior to that, I was an All-American athlete at Stanford. My physical feats were something that I sort of assigned value to, and others absolutely placed value in what they saw me doing or accomplishing with my physical feats. I mean, I had a C6 cervical spinal injury, which was I had an incomplete spinal cord injury, which meant that essentially there was still the thought or hope that I may regain some function, as opposed to something that you call a complete injury, which means below the level of injury, you didn't expect to get any more function. And any of you that have done neuro and you localize the lesion, with my C6 injury, I had upper extremity sort of disability as well. And at the initial, I had very minimal use of my hands at that time. And I was blessed with some return of motor function. And for anyone that sort of has seen disability or spinal cord injury, my hands do not function as some sort of a typical C6 quad would, as people think. And I'm primarily a wheelchair user, but I'm able to walk with crutches or a walker now as I regain some motor function. But the truth is, people have directly said to me that I would never be able to be a doctor again, and that how sad it is that I've lost all the things that made me who I was. And luckily, I had my family, and I have a faith-based practice that made it such that that didn't creep into my head. It was really just, what is it that I need to then figure out to be able to do it? And I think that's what has framed the way I view the rest of my time here. Is not that there's something wrong with me. It's that I need to figure out what I need to be able to do the things I am able to do. So that's sort of how my journey and career in medicine has now been framed around this, is that, I even have a catchphrase, disabusing disability, to demonstrate that disability is not inability. Now, that doesn't mean that disability doesn't mean there's certain strengths and weaknesses that each of us will have, but those are not inherently negative, wrong, or bad. Those things are just different, and everyone has difference in whatever way it is: race, gender, ethnicity, socioeconomic status. And we should be able to find a way to celebrate difference and provide access for everyone to demonstrate the success that they can have.
Great, thank you, Dr. O. And both Dr. O and Dr. Marasco, you both brought up disclosing the need for particular accommodations. I was wondering if any of you wanted to speak to that, about advice for students for disclosing their disability or disclosing the need for accommodations. Dr. Zazoff, do you have any thoughts?
Yes, I have lots of thoughts. Thank you for asking me. I think times are very different now than they were when I grew up. We have the ADA, which mandates accommodation. Sure, people can still discriminate, and they do, if you have a disability. I think it's much less likely now than it was 30, 40 years ago. I've been advising people to be open and to ask for accommodations that they need, because they will be more successful and it will be less frustrating for them. And I also think when students use accommodations, other people see that and they go, oh, it can be done. So my answer to your question is, I would advise students to, yes, request the accommodations they need. And everybody has to decide what works for them. If you're deaf like me, some people run sign language, some people run closed captioning, some people run written materials. Everybody's different. Each student can figure out what works for them.
Great, thank you. And Dr. Solomon-Poor, I'd love to hear, as someone who has more of an invisible disability, how do you go about sort of disclosing what you're dealing with, what you need in order to function.
Thanks, Alexa. Yeah, I've already learned so much from my colleagues, so this is really great. So I was diagnosed with type 1 diabetes at age 5. And that kind of irrevocably shaped the whole course of my life. You know, going into medicine, developing a career focused around my disease. I'm an endocrinologist, I'm a physician scientist, I run a research lab focused on molecular mechanisms of diabetes. So this diagnosis kind of changed everything. And so my life has been shaped around that. And, you know, I think that one thing that is important, you know, you mentioned an invisible, you know, disability, is that, yeah, people don't look at me and they don't know what's going on. And so this actually applies to one of the, you know, even though I'm primarily a researcher, I run a clinical program as well. And the kind of the hallmark of the program that I run, this diabetes transition program that helps young people with diabetes transition from pediatrics to adult care. The hallmark of the program is advocacy, self-advocacy. And it, you know, this is just the way I kind of naturally approach things. If you can't advocate on your behalf to say that you need things, then sometimes, especially with diabetes, you know, people won't know, or it won't occur to them. And so that's been kind of important to me, is to always be your own best advocate and your own best supporter, and, you know, to level with yourself in terms of what you need to be successful. And I think Dr. Zasov just pointed out, like, you know, if you're comfortable doing that, then your colleagues will also be comfortable, who are in maybe similar and maybe adjoining situations as you. And so that was something that I was not particularly comfortable with in medical school, because I just didn't know any better. And, you know, this is now like 20 years ago. So I looked at it as, I can do everything everyone else can do, and I have to do it better. And sometimes I put myself into bad situations because of that. You know, in terms of my diabetes care and how I was doing with my diabetes care while on service or on rounds or on call, because I wanted to go beyond. And I think it became very clear to me during my residency that I had to be very straightforward with what was going on with me and the people around me, and advocating and setting up the right networks so that I could be successful. And if I did need support, that people knew I needed support. And so sometimes those lessons were hard for me to learn. You know, so when people talk to me now, I am very much like my colleagues here. I think you have to be proactive and you have to advocate, because then you will put yourself in a better position to succeed. And I feel like things are better now than before. That doesn't mean things are perfect, of course. We still have a lot of room to improve. But I feel like, at least, you know, when I encounter, you know, in endocrinology, I get trainees that naturally also have diabetes. I'm not the only person with diabetes doing diabetes care, of course. And I feel, when they disclose that to me, I feel like I can be comfortable and say, like, well, what are you doing to make sure you're successful and that you can care for yourself and do the best for your patients? And so I feel like there's been progress, but I think things like this, like these forums, are crucial, because there are people that still aren't comfortable disclosing maybe, you know, circumstances like mine, where, you know, unless you're really looking at me carefully, you're not going to see the insulin pump tubing sticking out of my pocket, right? You know, you have to, I think, be proactive, whether it's visible or invisible, to make sure you get that you can set yourself up for success.
Great, thank you. Dr. I see you've raised your hand, and to Dr. Zasov and Morosco, feel free to do the same if you have anything in particular you want to jump in with. Dr. O, please.
This is Dr. O. I just wanted to add two very quick things to that. Is one, I think specifically in this setting, it's important for us to call out learning disabilities and mental health as well, because within specifically medicine, as we talked about sort of some of the ableist framework that may exist, there is still a belief that if you have a learning disability, that means that you can't learn. That means that you're not smart. That means that people will say things like, well, I mean, medicine is hard, so it can't be for everyone. And therefore, we can't make concessions for people if they have a disability, right? If someone can't manage their own emotions, what are they going to be like in front of patients? And so I think that that's something that, particularly in my role now at this university as the person who's the interim director of our university-wide services for students with disabilities, I want all students to hear that is wrong. Okay, I just want you to know that, and that, as Dr. Zazoff mentioned, the ADA provides protections for individuals with disabilities to get equal access, so equitable access to your educational resources. And so therefore, if we recognize that someone may need insert specific accommodation here, we need to recognize that does not mean that person is not good enough, is not smart enough, is not working hard enough, is just making an excuse. And that's something that is difficult for some people to understand. And it's even harder for learning disabilities and mental health disabilities as it is for physical disabilities, because I think people can see, oh, if we can accommodate this by providing some resource that's just something structural, they don't think that that's inherent to that person's ability to be a physician. Now, sometimes they do. And I will say that, at times, yep, Dr. Marasco is going to chime in. At times they probably do say, well, if you can't operate in this way, then you shouldn't be able to. So I'll let her chime in before I even give my second point, because I want this to be an exchange. So
Yeah, I think that's the only point I would make. I've probably been more hard-ass than many people about these things, simply because I do think ultimately we are here to take care of patients. And ultimately, this is not about us. This is about patients. Patients are supreme in all of this. If we can accomplish that with some accommodation, that's great. But for example, if you were to tell me that you were losing vision and you wanted to be a surgeon, and that you felt if you just had someone who would interpret what was being seen in the operating room for you, you could do the surgery, I would say to you, I think you're not thinking about the patient. So I really do believe that one of the things that's very important is that we recognize that our disabilities, even as physicians, should never compromise our patient. If the system can accommodate us to accomplish that goal of good patient care, then it's the system's importance, need. It has to do that. That's what ADA did. I mean, a curb cutout should not stop us from coming to our job. The ability to have necessary interpretive services for hearing disabilities shouldn't stop us from doing our job. But we have to be able to still, one, do the job, and two, always make sure that the patient is considered first and foremost in the process of this.
I agree 100% with Dr. Marasco, and will say quickly that there are a lot of things that we have not seen that can be done. And I err on the side of saying, let's see how we can work to yes before we assume the no, because there are a lot of things that many people look at us and they look at our lives with disabilities and they assume we can't do something, rather than letting us find the opportunity to demonstrate how we can. And so I'm sure that, even in my short life post-disability, people think I can't do certain things. And I say, well, I can, but you haven't given me the opportunity to show you that I can. And therefore, when you give me that opportunity, I will show you that I can do that. And that hasn't changed anything, right? And I think in medical school, however, people don't have to graduate medical school as a pluripotent stem cell. And I think that what we do here in our educational framework is that if someone, in the example you brought up, if someone is blind or low vision, and they want to be a physician, there are plenty of things that they can do as a physician that will change the world of medicine, but they have to get through medical school first. And if we put up barriers to their education such that they can't show what they can be because they can't get through this particular rotation, we then do put up a block in that system to prevent someone who could be an amazing, health services researcher with their MD, PhD, that may not have to use their vision in the particular field they choose to go into because they haven't differentiated yet. But what we're doing in medicine is we're then putting that block up in school to say you can't be a neurosurgeon, so therefore we're not going to be able to get you through medical school. And that's just where I don't want us to close the doors to the opportunity for brilliant people to then get into medicine that don't all have to be surgeons or don't all have to be insert whatever specialty here that might require certain things that even I will argue years ago, we never knew Da Vinci was going to be around. And the types of things that we can do with the Da Vinci now, we couldn't have done before. And there are plenty of people that then now have opportunities to then operate in ways that they wouldn't have been able to operate without that technology. Sorry, Dr. Zaza.
No, I think you're both saying the same thing in a way, but I think the difference is the last 20 years, the explosion in technology has changed everything. And so I think about a deaf anesthesiologist who couldn't hear me but had this way, a little microphone, and somebody would type in the captions and he could see everything that was being said and was able to participate. So I agree. I think we need to take the perspective, you want to do this, let's see how we can make you do this. And it's possible you can't do that, in which case you have to think about it and decide what you want to do.
I will just say that the opening line on my chart at the medical school that I eventually trained at and became a resident at and did a fellowship at had the opening line of this unfortunate 5-month-old female. And I read that for the first time when I was a chief resident in neurosurgery at Columbia. So the times they are changing. And again, what do they say? 3 perspectives. There is the truth that is your truth. There is the truth that what other people see you as. And there's probably the truth as to who you really are.
We said the same thing when I was first diagnosed. That I told my parents I'd be lucky if I became a janitor. So.
Yeah, so something that a lot of you, that I'm hearing from all of you, is encountering stigma, bias. I'm curious if that in any way directed the way that you approached your training or the way that you've approached patient care since. Yeah, I'd love to hear Dr. Zazov, I know you mentioned as well.
I am probably not the best one to answer how I approach training because I grew up in an era before ADA, before technology. I was the 3rd person in the country who was deaf, who became a doctor. I didn't know I knew one of them. I'm sorry. So there were no accommodations. But I think it was, you see, Corinne said earlier, Dr. Murasko said earlier, you have to think out of the box. And that's what I did. When I was on call, I would take the telephone and sleep with it so I could feel the phone vibrate. That's how I knew that they were trying to get a hold of me. I mean, you just have to think out of the box and pursue. Right now, as a physician, I do use some things like for our faculty meetings, we have a sign language interpreter for me and Dr. McKee, and we make sure that I can hear everybody speaking all around the room. And I think those are accommodations and technology that we have now available that people can use. There is an office for students with disabilities in the main campus, and there's also a similar office in the medical center that will help you get the accommodations you need and talk to you about it. I think one of the things you could think about, if you don't quite know which is best, talk to those people.
And I'm wondering how you approached dealing with bias, how you approached conversations with colleagues or with trainees in order to mitigate this sort of perceptions and bias.
So, and Dr. Murasko and I have talked about this before, she and I are chairs. We can get things done because we're chairs. People treat us differently. So, I mean, I think the great example that she uses, and I don't want to take words out of her mouth, is when she's in the highway, she can have somebody open the doors for her if I don't have automatic door openers. Most students don't have that. So I think, like I said at the very beginning, you have to advocate for yourself. And I did not do a good job of that when I was young. And that was a mistake that I made. I now know if I need something, I advocate. When we came in, the first thing I said to the host today was, can you please turn on the caption? I advocate for it now. I'm at a point where I realized, and I've learned the hard way, you have to advocate for yourself. And that's what I tell the trainees who have come to me for advice.
I think you have to value yourself too. I mean, I think if you don't place value in what you do, others will not. I know that, for example, when I was applying to neurosurgical residency, they had never had a woman. They had certainly never thought of having a woman with a disability in the residency. And so I said, well, what does it take? What do you think it would take to become a neurosurgeon? They listed a series of multiple things that needed to be done during medical school. I came to them in fourth year and said, okay, the checklist has been completed. Now, why can't I be a neurosurgeon? And, they're kind of left at that point back on their heels. And I think at that stage, people began to think differently, but it was still always a question. And so you need to, I think, advocate for yourself. I think you need to also understand realistically what you can and can't accomplish and figure out what are the ways that if you want to accomplish things, you can get that done. And so it means having some trusted advisors and mentors. It means having some friends. I find now that as a physician with a disability, one of the things that many of my patients and their families will talk openly about things they would not talk about to others, because they appreciate that I'm coming to them not just as a physician and a neurosurgeon, but also as a woman, as a mother, as a person with a disability, and that I'm not afraid to make use of those talents or those parts of me to help better take care of them as well. I'm very honest. I would not trade all the tea in China and all the wonderfulness of being young to be between the ages of 13 and 18 again. Those were not great years to my mind. So I very much relate to the teenage population who's going through that metamorphosis of becoming an adult, as at the same time that they're also navigating those waters as a person with a disability. And I recognize that, and I see it, and I try to understand it, because I think sometimes, particularly if it's a child that has a disability, their able-bodied parents may not quite know what to deal with it and necessarily understand the complexity of that for their lives.
Yeah, this is Dr. O. I'll add something briefly too. We've mentioned multiple times that you need to advocate for yourself. And I think for sure, Dr. Zazoff, who is my chair, knows that I am not afraid to speak up at times. But I think what's important to also mention is that while it is important to advocate for yourself, it's important for the systems to realize that there are people in place to then advocate for you. And as they both mentioned, as being chairs, they are in a particular position right now where they do have certain liberties that others do not. And once again, recognizing that in this system, not everyone values you in that same way, right? You need to advocate for yourself, you need to value yourself, but there are other people that do not see that same value. Now, that doesn't mean, as Dr. Marasco was saying, that doesn't mean that your value is any less. That doesn't mean that you do not have the ability to do something that they're not giving you access to do, but it does mean that you will still encounter barriers, and sort of resilience and grit are important, but there are people that can open doors for you, as we were talking about, and those people need to do those things. And so I think that we need to make sure that the system recognizes that there are people in positions that should be opening those doors for you, and then opening them and letting you in, instead of telling you that you need to go and break that door down, because there will be doors that as a student will be very, very difficult to near impossible for you to break down on your own. And there should be people there doing it for you. And as Dr. Zazoff said, there's Office of Services for Students with Disabilities. And then you also have Charlotte O'Connor directly in the medical school. And so there are resources that exist to be able to do that. But I do think that we need to then bolster those and support those resources a bit to make sure that other faculty, staff, students recognize that this is not an unfair advantage that someone is getting. This is not a student that's not capable, competent, or qualified. And so I think that the self-advocacy is important, but then recognizing that there are people in the system that can also sort of emulate the fact that we should be publicly stating that disability does not make a student any less capable. And something that I've been doing in some of the talks that I give is I talk in particular, the one that I like the most is when I talk to OB departments. I talk to OB departments because, as Dr. Marasco said, she said, this unfortunate 5-month-old girl, right? You all have had that lecture of breaking bad news. It's almost always something that then leads to disability, right? Someone has some sort of thing in their, you have a prenatal ultrasound and you're supposed to then go break the bad news of what it is that this child is going to have, which will then lead to some devastating life, right? You're going to have someone who had, you're going to be born deaf, and then they're going to tell you all the difficulty this child is going to have. And so they're breaking that bad news. We need to change that narrative that then disability is not a 4-letter word. Disability does not need to be seen as bad news all the time. And once again, don't want to take words out of people's mouths, but I think that if I have learned a lot in my past 8 years with disability, that if you take, for example, the deaf and hard of hearing population, that's a culture for many people that they do not feel as though they are lacking anything that makes them any different, right? Now, not everyone that is deaf feels that, but that there are cultures within this, that this is just a different way of living, that we use all that we have to then be fully valued. And so I think that when we in medicine continue to frame it, that disability is a less than, right? It will continue to perpetuate that ableist norm. But as Dr. Marasco said, there's absolutely nothing wrong with acknowledging the things that you can and cannot do, because none of us can do everything. And so I think that that is a balance that we need to have, to say, yes, there will be certain things that I cannot do. And that doesn't mean that I am not capable or qualified to do other things, however. That does not mean that overall as an individual, I'm not smart or I'm not valuable. But I think that our system does perpetuate that belief by the hurdles that we put people through. And one of the things that I mentioned, just to bring the intersectionality of this space together, is that this has happened for marginalized groups for years, whether it's women, whether it's people of color, whether it's people with disabilities. This is something that I think we are reckoning with now, that our world has not always valued people before. And we are now seeing that we need to then directly demonstrate how we value them. And certain people have been, Dr. Zazoff, Dr. Marasco mentioned this. It's kind of the back when they were coming through, things were not being discussed as openly as this, right? They had to do what they did, but people coming behind them should not have to do it that same way, right? From everything that they've experienced and learned, we should be able to say that you shouldn't have to be the one breaking those walls down on your own. There should not need to be such a expectation of self-advocacy if we've gotten to a point where we recognize that these things are going to be given. We will have students with disabilities at our medical school, and therefore it should not be a surprise when someone has an accommodation need, and it should not be something that is so difficult to obtain because we now see that this is going to occur. And I think what's important for us to then start to then perpetuate and advocate for, is that those things are built into the things that we do. And it gets to the conversation of universal design, because one of the statements I say is that everyone can use the ramp, but not everyone can use the stairs. And so therefore we need to be building more ramps to provide the access that people need to then show how they can be successful, because giving that access doesn't guarantee that that person is going to be able to do it, because you still have to bust your butt and do your work. But if you don't even have the ability to get into the building, you're not gonna be able to show them what you can do.
Thank you. So something I've been hearing from a few of you is looking for individuals who are role models, who have dealt with similar situations through their training. And Dr. Stolman-Parr, I heard you mention something about that earlier. How would you recommend, or how do you see the role of mentorship for trainees with disabilities and chronic illnesses? And where have you found community?
Being someone who runs a research lab and who has students and postdocs and fellows and regularly working with me that require, supervision and mentorship, this is, I think that the need for mentorship and support, it permeates everything that we do in medicine and in science. So I think that, the thing that sometimes people think about is that mentorship is like a formalized experience. Like when you're in medical school, you've got your intern that you're working with, or your resident. When you're a resident, you have your attending, or you have the fellow when you're in fellowship, and so on and so forth. I think that mentorship, it talks to community. I think this is also another theme that's coming up, and having allies. And I think that mentorship doesn't always have to be a formalized process. So there are, I think there is infrastructure now, and it's emerging, and you heard Dr. O talk about that, and I think that's really important. But I think that there's formal and informal mentorship that really helps for you to find that path. The same voice that could help mentor me in my training might not work for someone who has the exact same illness as me. Right? Mentorship is not like a one size fit all thing. And so sometimes that requires, again, you need to have systems in place where there's support and networks around you, and those have to be developed. And I think trainees can hopefully find those, because then they're going to want to go to those places to train and do well. And then it's also, sometimes as someone who is experiencing these things and coming up, you look into your current environment, and then, you hopefully are social, and you ask, and they say, oh, did you know, like, Dr. So-and-so's got diabetes too. And, oh, I didn't know that. And then, you make these informal connections, or you go to conferences, or you find and develop these communities, and some of them are institutional, some of them are in your field, some of them are outside of your field. But there's a social aspect to this, I think, that is important. And so, that I've been lucky that students feel comfortable and trainees feel comfortable just bringing that and disclosing that to me. And so we can kind of cut to the chase, and I can say, here's what I went through. Here's how I can be helpful for you. And similarly, I had, mentors along the way that if they didn't experience it, they've had trainees that were in the same boat as me, and they said, what can I do for you? And this is what I did for them. And is this helpful for you? And so, if you find those allies and those mentors, either directly applicable or indirectly, informally, I think those put you in a good position to not feel alone. I think that's a hard part, is that, like, medical school can sometimes be isolating, independent of, chronic illness or disability, just because of the demands and how much you have to work on your own and read and study. And so that isolation is hard. And so I think there's a big important component of community that helps in these aspects.
I think one point I would also make is it's not a weakness to ask for some help. It's a sign of the fact that you're human. And I also think you just want to keep in mind that if you can keep your own humanity about you, I think it does make you a better physician, because too often we put ourselves into this isolation of, I don't know, I think it's done as a mechanism to keep us sane and safe. A lot of what we see is sadness. There are things that we deal with that are difficult. And so sometimes we develop this magical thinking that these are our patients and then there's me as a physician, when in fact we're very one step away from being a patient. And I think keeping a little bit of that, I think of it as humility, but understanding that we're human, I hope makes us better doctors. I think it certainly makes us better prepared for the realities of life, which are not insignificant. And it's important to understand and embrace that, because I think it keeps us psychologically stable. And it's important. It's important because we are all human. We just happen to be humans with a unique set of training and language that we're applying to others. It doesn't mean that we're not like them and like all the people that are patients. We are. We just happen to have we're using a lingo that they're not using.
Great. And Dr. Zazav, I know you have to duck out to go to clinic. I was wondering if you had, before you leave, any final thoughts or advice that you would give students with disabilities and chronic illnesses about navigating practice or training. Oops, you're still muted.
Phil, you muted.
I'm thank you. I'm just gonna reiterate what Dr. Marasco said. Each of us has something about us that makes us unique that we have to deal with. In our case, it happens to be a disability, being open, being transparent. Other people come to us, they feel more comfortable talking to us. I think we can provide care in that way, and we can also be a role model. And I think the more of us, the better. People just need to be comfortable in advocating for themselves and to remember the law is on their side and there are people out there to help. Thank you for having me. I wish I could stay longer. Thank you.
Thank you so much for being here.
Bye.
Great. So a few of you have brought up disability advocacy, building community. I'd love to hear some thoughts about that. I know, Dr. O, you're very involved in building those communities at U of M. Love to hear your thoughts.
Sure, this is Dr. O. I would say, touching on the conversation and the question that was just asked in terms of mentorship, I think that it's also important to recognize that mentorship is not unidirectional. And I think that that's where it comes from, sort of this conversation about, disability advocacy as well, is that I have learned a lot from people that are sort of behind me in this process. And I think that, this goes to this notion of medicine even more, though, that you don't have value within this system until you're tenured, or you don't have value until you're, have reached whatever level. But I think having value and being the one that makes the decision are two different things. And not everyone that is a decision maker necessarily has the same sort of perspective that someone else may have. But when they then value the perspectives of other people when they make their decisions, that is what makes you a leader. And so I think being able to listen to people along all sort of parts of this structure, and listening to students and having students have a voice at the table of something that maybe we don't understand as much. I do not pretend to know everything about disability. I do not pretend to know everything about anything that I talk about, but I do recognize when there are other voices in that space that then can support and then influence the decisions that we make. And so, yes, I mean, there's the Medical Students for Disability Health and Advocacy group that was started up. That is just one group here, but then there are groups all across the country that are doing this. They're partnering with the student groups across the country to do these things. They've already had an impact at Stanford, and they're working with people at Dartmouth. And so there are national organizations as medical students that you can be part of. And so there's also the Alliance for Disability and Chronic Illness in Medicine, which is another one of the medical student groups that has come together. And so, within medicine specifically, yes, there are groups that are speaking out to then advocate for disability and accessibility needs. And I think it's also important to recognize that based on intersectionality, while representation is important, and I say this all of the time, right? People talk about how you can't be what you can't see. I disagree with that, because as Dr. Marasco will say, there was no one that she saw that was exactly like her doing what she did. So it's not that Dr. Marasco said, oh, I see someone that is exactly like this, and that's why I know I can do this. No, she just knew I can do this, and I'm going to show you I can do this. And I remember when I was considering coming here, or shortly after I got here, she said exactly what she said earlier today, is that she wanted to be known as the best darn surgeon, period. She didn't want to be known as a female surgeon. She didn't want to be known as a disabled surgeon. She wanted to be the best surgeon. But I think that what people need to see after that is she is a female surgeon and she is a disabled surgeon. And those things, in my opinion, make that even that much more special. And so you can recognize that your mentors may not be exactly like you, right? It might not be the experience that they've had with type 1 diabetes, or it might not be the fact that they're deaf or hard of hearing. But if you then find people that then can help you along this journey, it doesn't have to be that Black people only listen to Black people, women only listen to women, and disabled people stick together, because what that will do is it will then further bring these things into silos, and it will not allow us to see the mutual humanity and the diversity of our lived experiences. And that then makes us better physicians for our patients, because as I put in the chat earlier, all of us is someone's patient. And so it just depends on what hat you're wearing that day, or what side of the stethoscope that you're on. Dr. Zazoff is going to clinic right now. I am in my clinic office, and I have clinic this evening. I will be someone's patient later on, but today I'm going to be the physician. And that is not a power dynamic that is because I'm better than you. We are all on the same team and we work together as a team, because guess what? Medicine isn't my entire life either. And so when I am not someone's doctor, I actually went, funny enough, I went to go take my taxes in the other day. I go to take my taxes into H&R Block. The person behind the desk, all masked up and everything. And I wasn't paying. I just came in, did the thing. And then this person said, Dr. O? And I said, what, who is she? She's like, it's so-and-so. It was one of my patients. I haven't seen her now because she's a young woman. And long story short about why I haven't seen her, but 3 years older when I last saw her and she was 15, right? She's now 18 years old, working at this job, looks like but I was just out in the world, right? Out in the world seeing someone and there was no power there. I mean, I was giving her my tax information, you know what I mean? And so I think recognizing that we are all human. And yes, within the field of medicine, we have, as Dr. Marasco said, we have certain knowledge that we have amassed. We have a lingo that we use, but that doesn't make us any different than anybody else out there. We're just a different member of the team trying to make this world a little bit better when we leave it than when we came in.
Fantastic, thank you. Since we only have about 10 minutes left, I wanted to open it up to see if anybody here had additional questions that they wanted to ask our panelists. Feel free to just turn on your video, unmute, and jump in if you do. Okay, well, if anybody does, feel free to jump in later.
I think the other comment I would just simply make is that when you're looking at your patients and you're trying to assess how you can help them as physicians, again, worry about that word assumption. Don't assume you know what they should or shouldn't do. I think you can give advice, but I don't think you can say, oh, that will never happen. I'm always struck by the fact that people are really much more resilient and much more capable of finding ways to accomplish something. I think you can rightly and appropriately ask, gee, do you think the amount of energy you're spending to do this could be spent in a different way on something else? And usually people will tell you when they get to that point. I will give you a very good concrete example. I deal a lot with kids with spina bifida that have open spinal defects called myelomeningocele. And many of these children are very ambulatory for about the first 5 to 8 years of their life. And then somewhere usually between 10 and 12, maybe 13, their size becomes a disability in the sense that they just simply don't have the muscle strength to walk anymore. And they're spending inordinate amounts of time getting from one place to another and enormous amounts of energy to do it. And their parents are very gung-ho on them continuing to ambulate rather than using a wheelchair. And pretty soon, they begin to isolate themselves because they're spending less time out doing things, and their parents are going, oh, must be because they're a teenager or having problems. And what you find out is it's when you really get to it, it's not that. It's just that the enormous volume of energy and effort they need to put forward to be able to get out makes them almost dread it. You know, it's like they're running a marathon every time they're going to the mall or something like that. And to be able to warn the parents about this before the question is raised, it doesn't mean that you're admitting defeat, that you're not ambulating. It simply means sometimes the physics of it make it that you just can't, and that the energy would be better spent using a wheelchair and getting there and being engaged and involved and everything else than it is to be spending all of the energy getting from the parking lot just to the front door of the mall. You know, and so I think those are just things I would comment on. It's very hard for an able-bodied person to ever decide they're going to use something to help them. Well, except when you want to take a handicap spot when it's, you can't get into a store and it's Christmas time. But I you know what I'm saying. Most people would dread the thought of having to do that. Trust me, they're no different. I mean, folks with disabilities are the same thing. We got a lot of pride. We don't want to have to ever do those things. But sometimes there's a logic to it. Watch adults when they get to older and need reading glasses. They'll do anything and everything they can to avoid having to use them because somehow it suddenly admits that they need something, some accommodation. It's the same when you're dealing with some of your patients. So sometimes you have to help them see where there are little things that can be done, things that can help them that make it logical. It's just sensible. So I just give that as an example.
Sorry about that. My internet cut out for a minute. But great, that's fantastic. I appreciate all those thoughts. So now that we have just a couple minutes, any last advice, again, like I said, for students with disabilities about navigating, about bringing up these conversations, about deciding to use accommodations even and kind of reveal their disabilities. Dr. Solomon-Ford, you want to start?
I want to just say thanks for inviting me, and thanks to my colleagues here. I've learned a lot from them, and it's good to actually, in this COVID world, meet them. I feel like I know them because they're both actually quite I feel like quite famous around our campus. So now I feel like now I know them, and hopefully they know me, which is great. But I guess in the spirit of time, I won't give a particularly long wrap-up message, but just to say that hopefully the students who are here should know, and I don't want to be too bold to speak for my colleagues, but should know all of you should feel welcome to reach out to any of us. I'm sure that, in Karen's case, she's a chair, so there's going to be a longer queue in her email than maybe Dr. O and myself, but feel free if we can ever help you or, in any capacity, connect you with people that you want to talk about your circumstances or where we can advise you. I think that you should know that what I was excited about participating in this panel for is giving people opportunities and outlets to find those informal mentors that might help them, or people to bounce ideas off of, or just to vent. I mean, med school is hard already. And then, you have other confounders to make it harder that, we're happy to be there to support and to listen. And joining this panel is a testament to that.
Thank you so much. Yeah, I really appreciate that. Dr. O, any last thoughts?
I talk too much. I definitely don't want to be the one with last thoughts. I will concede my time to Dr. Marasco.
Well, I just want to say thank you. I think it's great that you guys are thinking about this, and I think it's important that we respond to it. I like being a mentor, so if there's anything I can do to help or advise or offer assistance, please let me know. I very much am of the opinion that, some of the difficulties I had were probably things I created for myself by not being honest and necessarily opening up about where I thought there were needs. And I will just simply say that probably I've got 2 high school students right now at home thinking about college. And all I can tell you is that the most difficult thing I've ever written in my life was one of my essays to college and to med school and to residency, in which I tried to put in that I sort of had a disability, but it wasn't really important. And I was going to be really good for whatever they were going to do, because I was trying to make sure that that wasn't the most important thing, that, the qualities and the things I brought to the table were valuable. And the disability, if anything, was just a little bow on top. So I think it's great. Ask your patients. They're going to teach you a lot about themselves. And know that some of the things that you can do to help them are just helping them get past their disabilities. because there's, a really a great opportunity, particularly with the new technologies, to really just go beyond and do more. So thank you. I think this is I'm really grateful that you actually thought about this and asked us to participate.
Yeah, and we're very grateful that you all agreed to participate. This has been such a fantastic discussion. And thank you all so much for your time. And thank you to all the participants.